Okay, this is the third part for part 2 of the neurologic system. I'm continuing from slide 130 of the presentation. Um, Notice that vital signs and reflexes return to normal within seconds, uh, and then consciousness, either partial or full, within days or even less. Um, then we can talk about the third bullet of slide 130 where everything becomes worse. Slide 131, notice the first bullet regarding unique symptoms. Uh, um, and notice that it's not only a unique symptom, it is an extremely unique symptom. What else? And then the three options in bullet 3 being acute, subacute, or chronic, a matter of time and definition, usually located on the top area of the skull. Slide 132, when we talk about the word expanding in the third bullet, obviously we're talking about increasing pressure, mechanical pressure, as we've talked about before. Slide 133, please go over the flow chart here. Very important. Basically, it's the background for the whole presentation and the understanding of mechanical pressure and how it pertains to pathologies, not only in this system, by the way, but especially in the brain, and how it's going to influence the progression and the extent of injury. So, very important. Slide 133 in the presentation, please visit it. Then in slide 134, notice the last bullet. There's a change to respiratory pattern, and that is extremely bad. Slide 135, there's the idea that the more time that damage takes to travel, so to speak, to get to the brain, the influence on the symptoms is different. You can understand this from the third bullet of the slide 135. And what I wrote to myself as a remark, that travel time of the damage from outer parts into inner parts equals time to severe symptoms. Okay, so there's a relationship there, a ratio there between how much time it takes to travel, so to speak, the damage from the outer part of the skull into the inner parts, and when severe symptoms occur. Obviously, because you are going from the outer parts into the higher centers of the brain. Um, what else? Notice in slide 137, the first 2 points being uh, pertaining to mechanical pressure again. Then in slide 138, once again, the idea of swelling within limited space, vasodilation, dilation, in limited space. Keep in your mind the idea of limited space and how that affects the formula for pressure. Then, of course, in slide 138, as you go between the points, as promised, the situation gets worse. Then from slide 139 all the way down to 141, it keeps getting worse all the time. Notice that in slide 139, the third point, we have a drop in blood pressure as a symptom that we can definitely identify in the lab. Also, the idea that breathing stops for a while, bradycardia, we can definitely identify that in the lab if we suspect something, the failure of reflexes as well. What else? Going all the way to slide 142, of course, we have, in this case, severe diffuse axonal injury because we are seeing an immediate dysfunction to the higher centers of the brain. And this is a combination of the two things that we talked about. A, higher centers of the brain leading to worse dysfunction. And two, the time that it takes to reach the inner parts of the brain. In this case, it's immediate. So the combination of both is making something worse. Then slide 144, talking about spinal trauma. Notice that once again, we have mechanical pressure in the background. And in this case, when we talk about the first bullet, the applied location or distance from the spinal cord will influence the torque that is produced, because distance is one of the two components of torque besides force or the application of force. So obviously this is going to increase the damage, the the more the force is greater and far or applied in the farthest point of the spinal cord. Notice in slide 145 that we're going downwards in the effects and symptoms. Then when we talk about dislocation, it really depends on what direction the force is being applied and the injury is being applied. But in theory, all directions are possible in injury. Then notice in slide 146, in the second point, that we see the symptoms 2 segments below or above where the actual injury has occurred, meaning it's spreading. Then in slide 147, we have scar tissue. In the second bullet, we have scar tissue replacing normal tissue, which leads always to the loss of function. So not a good idea. Slide 148, in regards to spinal shock, notice when we talk about dysreflexia, this is a life-threatening condition. Then slide 149, very important. Each and every bullet within itself is important to notice. First of all, the first bullet talks about unique symptoms. Notice the systolic blood pressure of above 300. That's a lot. Okay, remember that at 250 we stop exercise testing. So, and then you have erection of the hair on someone's skin, definitely noticeable. And the distended bladder or rectum is not something that you can notice with your bare eye. Of course, other symptoms accompanied, so think about the combination: pounding headaches. It's not normal headaches, it's pounding headaches. Blurred vision, that someone can definitely indicate. Sweating, well, that's not unique, right? Skin flushing, once again, think about the combination. Nausea and bradycardia. Then you can see that reflexes occur, but they're not functional. They're just physiological responses to stimuli of the peripheral nervous system. Let's see. Then we can talk about degenerative disorders of the spine. So slide 151. I didn't really write anything specific to slide 151, but in slide 152, we see how the loss of structure immediately leads to the loss of function, right? So that's the connection of anatomy and physiology, and that's one of the major principles that we've learned at the start of the course. And then you can see in slide 152, in the third bullet, that we have a structural defect. Once again, changes to structure lead to differences in how mechanical load is absorbed and dealt with, and that will lead to function changes or to injury, of course. Then we have on slide 154, we're talking about spinal stenosis, so the narrowing of the spinal canal. The narrowing of the spinal canal, once again, immediately affects that formula of pressure. So in this case, we are lowering the diameter of where force is supposed to be applied, and that is why pressure goes up. Then you can see that in slide 154, in the fourth and last point of the slide, the numbness, the pain, the leg tingling is basically the outcome of elevated mechanical pressure on the nerves. What else? Jumping to slide 156, to the last point, notice that when we talk about the hernia disc, we have literally content spilling out or moving out of the disc, which decreases the pressure locally but increases the pressure on the environment. Then in slide 158, you can see that if it's self-limiting or resolving, it's because mass, tissue in this case, of course, has moved back to the area. Then talking about MS, jumping to slide 161, talking about the first bullet of slide 161, we once again want to visit the idea that the myelin sheet has a protective and functional importance. So any injury, any effects, degeneration of the myelin sheet is going to immediately affect the work of the immune system and the chances of having infections and inflammations. And then usually the deceleration of the neural impulse, meaning that neural conductance is slowed down. Then notice that since both types of matter, gray and white, are affected, this is called multiple sclerosis. Okay, that's the combination of the two, because you have symptoms that originate from both injury to the gray matter and the white matter. So multiple sclerosis, and of course the scarring by definition. Then in slide 162, you can notice the four subtypes of MS. Their names, basically, if you remember them accurately, will give away what's supposed to happen. So let's just go over those. We have RRMS, which is relapsing remitting, right? So this is the most common course of the disease. It has clearly defined attacks, either new or increasing neurologic symptoms. Okay. Then you have periods of partial or complete recovery. So those are the remissions. Okay, so you have an attack that might get worse or might have new symptoms as time goes on. And then in between, you have the remissions where there's nothing. So on and off, on and off. Okay, then you have PPMS, which is primary progressive. So definitely a constant worsening of function, or as I wrote, accumulation of disability from the onset of symptoms um, without early relapses or remissions. So symptoms simply go and get worse. There's no stopping. It's on all the time. There's no on and off. It's on and it's getting worse all the time. Then SPMS, secondary progressive. Um, the relapses are there, but it's harder to identify them. Okay, so they're less distinct. And then when they do happen, you do not have a complete recovery from them. So you're constantly in a deficit. It's never back to normal. Okay. Um, then you have on slide 164 the four examples uh, that indicate that you might be shifting to SPMS. Last one, PRMS, progressive relapsing, includes distinct relapses, full or partial recovery. Between relapses, the disease continues to get worse slowly. Okay. Um, then you can see that they can be active or inactive, worsen or not worsen. So basically, we're playing between two things: the ratio between attacks and recovery, and how good or bad they are. Then the last two slides pertain to ALS, uh, which is a degenerative diffuse order. When we talk about diffuse, that's worse in this case, right? And we're talking about affecting both upper and lower motor neurons, meaning of different levels of centers. Um, you can see that in this case, neuron death is idiopathic, meaning we don't know the cause, and hence it is associated with genetic mutations, mainly toxicity, oxidative stress, and mitochondrial dysfunction, which is part of oxidative stress, and then impaired axonal transport. Basically, all the basic mechanisms of cell injury. As always, if you have a question, let me know. That's the end of the videos for Unit 4, the neurologic system, Part 2.